Good afternoon, and thank you everyone for joining us to Multi-Modality Imaging Conference. I'm Malahfji from the Cardiac Imaging Group, and today we're going to talk about MRI as well as nuclear and CT in the assessment of left ventricular function and hemodynamics. So I'm going to start with the MRI because it's the most important and it's the actual gold standard, and then Dr. Chang is going to talk about nuclear and CT afterwards. So I'll give you some caveats first for ejection fraction. Ejection fraction is the number that most everyone wants to know in the care of the cardiac patient. It's become a key parameter for really most cardiac care over the past 50 years. And we have to recognize, and this is a core concept that MRI is very important in elucidating, is that it has caveats to it. So here's an example of a person with a normal ejection fraction. And then here's another example with a patient with what appears to be a normal ejection fraction, but severe MR. And then if you compare the values, this is a person with 65%, and the number here is also 65%. But in reality, there's key differences between those two patients. This patient has no valvular disease, whereas this patient has severe mitral regurgitation, which you see here with the flail posterior leaflet. So this person's heart size is 164 cc's compared to 259 for this patient, which is enlarged. And then the end systolic volume is 57, yielding a stroke volume of 107, whereas this patient will have a stroke volume of 168. So the reality is the forward flow that actually leaves the heart ends up being similar between those two patients, as does an ejection fraction, despite huge differences in their heart size as well as their cardiac output with exercise. And in reality, if you just kind of restrict your focus to, what's the EF, you're going to miss a lot in many cases. Here's a third example. So what do you guys think the EF is here? Mildly reduced, moderately reduced, severely reduced. We don't need the exact number. Severely reduced, right? So do you think the cardiac output of this patient is similar to this and is similar to this? Their EF is much lower. It has to be a lower cardiac output, wouldn't you agree? Exactly. So this patient has a huge heart. Their EF is very low, 23%. But their heart is 434, the systolic volume is 334, and actually this yields a stroke volume of 100 cc's with very minimal MR, and in reality, the cardiac forward flow that actually leaves the aortic valve is similar to the other two patients, despite a very different heart. So this patient actually has a similar resting cardiac output compared to these guys, recognizing the caveats in systemic vascular resistance and hemoglobin, etc. But obviously this patient exercising will not do as well as these two. And then this patient with exercise may also start having trouble compared to this patient or this person. So this is not really an MRI concept, but you see that MRI will actually give us a lot of these assessments, which you can still get by echo, but because these two assessments of the flow as well as the volumes are done independently on MRI, you can clarify a lot of these more so than you can with echo in some cases. So this is the first message. The ejection fraction does not necessarily equal the cardiac output, and it doesn't incorporate left ventricular size, it doesn't incorporate loading parameters, which are obviously very important. So when we're thinking about contractility of the myocardium, there's this ideal, hopefully non-invasive parameter that we've been searching for, and there's not really a full parameter that incorporates everything, particularly non-invasively. So you want it to be sensitive to changes to inotropes and inotropic function. It has to be independent of loading parameters, which the vast majority of parameters are not. And then it also has to be independent of heart size and left ventricular mass, easily available, safe, and then obviously proven when it comes to prognosis as well as utilization and decision making. So we have not really developed a particular parameter that incorporates all of this, but the EF is easy, it's proven. There's a lot of data to support it in all sorts of cardiac conditions, and it's essentially withstood this test of time as a result. So where's the advantage of MRI when it comes to assessment of the ventricle as well as the atria? There's high spatial and temporal resolution. So with appropriate imaging, you can really achieve a time resolution. This is kind of your frame rate that is very close to what we can get on echocardiography. And then the spatial resolution may not be as high as parameter as techniques like CT, but because of the contrast resolution, which here refers to your ability to discern where the muscle begins and where the blood pool begins, so your ability to differentiate between tissues is very high with MRI compared to things like CT. This gives you an advantage despite not having as high of a spatial resolution. So this is the excellent signal-to-noise ratio, and then you can create any imaging plane you want. You know, if a patient is big, if a patient has COPD, if a patient has a huge pneumothorax, for the most part, this doesn't affect your ability to get these kind of acquisitions with MRI. And then when it comes to actual calculation of volumes and mass, there's no need for a geometric assumption. So with all of the echo calculations we do for ventricular volume and mass, there's almost always an assumption here that's made, whereas here it's free of these calculations. So the way we do this is, you know, one thing to think about for MRI is that it's not similar to CT in that you kind of acquire slabs or acquisitions, let's say through the chest. What we do is we acquire slices that you can create in any permutation you want. So you start first with an axial slice and you create sort of a slice that goes through the LV apex, through the left atrium, to create what we call a pseudo 2-chamber and a pseudo 4-chamber view. And then you optimize these further to create a true 4-chamber set of views that really go through the apex and optimize the right ventricular assessment where the actual slice goes through the largest section of the right ventricle. So from these two, we create slices that go as short axis images, and this is similar to nuclear where you get the actual short axis images of the left ventricle and right ventricle. We make these so that they're 1 centimeter apart. And as a result, you can use those to apply your Simpson's rule so that you say, hey, this cylinder is 1 centimeter in height. And then once we create these set of views, all you need to do is you actually trace or you do a region of interest on the blood pool of the left ventricle throughout each of the slices. You pick where the largest one is, you pick where the smallest one is, and here it's highly dependent on how you do these regions of interest. So if the patient has an abnormally shaped left ventricle, let's say due to a prior infarction, as opposed to echo, where there's an assumption of how that abnormality is positioned, here all you're doing is tracing it. So there's no assumption here as to what the shape of the cylinder is because your tracings will dictate what the cylinder looks like. And then you apply the Simpson's rule by calculating the thickness, which we said is going to be 1 centimeter, this is just our choice, and then the area, and then you create a volume. So you add up the volumes for end diastole, and you add up the volumes for end systole. Now, here what we do is we incorporate the papillary muscles within the left ventricular mass. This is by convention for the most part, but it's important for things like HCM where there's papillary muscle hypertrophy, and the biggest thing is to do it consistently for all patients. As you all know, the left ventricle descends into the chest cavity as it contracts, so we have to adjust for that basal slice, which actually during systole will descend further down. So you don't necessarily need to trace the whole thing during end systole, and this is where the variability and expertise comes in persistently getting the same parameters. So we use the long axis to help us decide where we trace, especially for these basal slices, and obviously you have to kind of incorporate the rest of the images to try to figure out where the left ventricle begins or ends and when the left atrium begins. This is even more important for the right ventricle, which even has more variability, and assessing the volumes is obviously a very key parameter for us for assessing valve disease and other findings. So notice that there's no gadolinium involved here. All of this scan that I just showed you does not require gadolinium, and you can really do it in 15 to 20 minutes. Nowadays, with faster processing techniques and faster acquisition techniques, you can do it in even a shorter period of time. And this will give you the volumes and the EF, essentially. And you can, from that, actually get things like strain and annular parameters. The reproducibility of this is very high. So whether it's inter-observer, whether it's intra-observer variability, particularly for normal size hearts, you're really going to get within 4 to 5 cc's. Really, the biggest source of variability is this kind of basal slice. And then obviously, if you don't pick the largest set of end-diastolic images and the largest or the smallest set of images, then you may end up with smaller numbers. But in reality, we get very close to each other when we do the same study. If the person has a huge heart, like that third example that I showed you earlier, that number is going to be a little bit higher. But it's definitely much better than what we do on echo. Even with experienced individuals on echo, you can still get much more intra-observer variability. And then this has been validated, all the way back to the 80s, even against sort of casts of human hearts. So this, as a result, has become the reference standard for calculating the left ventricular volumes. And then, obviously, let's say you have a procedure, or you have a tool, or you have a medication that has an effect on left ventricular remodeling. If you're designing a trial or designing a study to prove the utility of that tool, well, having a technique that is going to be highly reproducible will allow you to do the study with much fewer patients because it is highly reproducible. So let's say your tool or your device achieves reverse remodeling of someone with heart failure by 10%. Well, you can do the study with much fewer patients if you use MRI as your reference standard for calculating the reverse remodeling extent. All right, now how we do this, and I think Dr. Shah had done the physics talk a little bit earlier. To kind of give you a brief overview, like I mentioned earlier, this is not done the same way as CT, where here in MRI we use what's called a K-space, which is kind of this virtual platform where we put in frequency data, and with every heartbeat to get one image, we use this K-space to put in the lines of data that we acquire. But every line of data that goes into this K-space contributes to the entirety of the image in some way. So it's not going to be, section number 1, section number 2, section 3, and 4. But the more K-space acquisitions you get, the better the resolution as well as the imaging characteristics of the image, so that usually to get one image like this, the reality is MRI is slower compared to echo and CT. So you very often need to use multiple acquisitions. And obviously you have to account for the fact that the heart is moving all the time and the patient is breathing. This is where the challenge and the nuance of MRI comes in, which is you have to do your acquisition as fast as you can while the patient is holding their breath and achieve diagnostic quality imaging. So to get this just one image, back in the old days, it needed even more heartbeats. And to get a movie like the one that I showed you earlier, you have to get multiple images throughout the cardiac cycle. So what we do is what's called segmentation. To get a movie, you have to play multiple images over time, right? And you have to acquire that time resolution that I was referring to earlier, where each of the frames is separated from each other by 30 to 40 milliseconds is the ideal parameter that we reach to. So the patient will have to hold his breath while you acquire continuously throughout the RR cycle for at least 5 to 6 heartbeats, and then you acquire these K-space lines that I referred to earlier, and you kind of bend them towards together to create that final movie that I showed you earlier. So because of this, there's a requirement that the patient should have a regular R-to-R interval. And if the patient has AFib or a highly irregular RR interval, we have multiple tricks and methods to get over that. But the reality is, the ideal scenario is someone with a not very fast heart rate who's able to hold their breath and able to actually also go through what sometimes feels like a tomb inside of that MRI closed environment. So if the person is unable to hold their breath, this typical acquisition that we get can still be achieved by what we call real-time imaging. And this is the older version of this, where even if the patient is not able to hold their breath, we can use acceleration techniques to still get what very often is still better than echo. No offense to the echo people. But you sacrifice your frame rate, and then you sacrifice your spatial resolution. If you're trying to resolve, a tiny vegetation, you're going to miss it with this kind of acquisition. And then even for this one, because this is acquired over multiple heartbeats, if you have something that's moving randomly as opposed to the left ventricle, then you're also going to create these ghosting artifacts. Nowadays, we use what's called compressed sensing, where you can acquire this much faster, and you can acquire multiple of these slices over just one breath hold with very close time and spatial resolution to what we do with the standard technique. So when it comes to left ventricular volumes, there's reference standards for normal individuals according to age and sex and athletes. And the key thing to recognize is that these are still highly different than the reference parameters that we use for echo. So for example, for men younger than 60 years old, the reference range for end-diastolic volume is between 119 and 203, but for echo, it's between 62 to 150. So a person with 140 will be normal here as well as here, but if you get someone who gets up to the 190 cc's range, by echo, that's going to be considered significantly abnormal, whereas it's going to be normal for MRI. And the same applies for left atrial diameters and volumes. And then when it comes to 3D echo, notice that the reference range is a little bit larger, but it's still not the same as the reference ranges for MRI. The key thing is going to be your ability to resolve the trabeculation of the left ventricle, which we'll get into. And then the other parameter is all of these geometric assumptions and the foreshortening that we get with biplane LV echo volumes. So a key thing to remember is what's considered a normal heart volume or heart size tends to be smaller for older individuals, and that's more affected to the end-systolic volume. So as a result, the normal ejection fraction for older individuals is considered to be higher, or is going to be higher. And then even if you index to BSA, with MRI, the volumes of men and women will be different. When it comes to agreement between the two modalities, the short summary is for ejection fraction, there is usually not a dramatic under or overestimation. For end-diastolic volume and end-systolic volume, the usual underestimation can be anywhere between 40 and 50 cc's, where you get an EDV of 200 on MRI but 150 on echo, and the underestimation or the extent can be even higher the larger the heart. So once you get to these 400, 500 cc's, you may get 500 on MRI and 300 on echo, and that's normal. So this was tested when it comes to 3D echo, and this is now an old study, but it's really a seminal work essentially in this area, where they looked at 3D echo, and what they found is the bias or the negative bias for end-diastolic volume is 67, and then 41 for end-systolic volume. Your EF bias was minimal at 3% difference between echo and MRI. And then more experienced interpreters for 3D echo had less bias compared to less experienced. They also had a phantom model in this study where they actually looked at a true water balloon volume of 150 mLs, and notice your tracing of these parameters just with minor differences can give you highly different results. So what you have to kind of train your eye towards is trying to trace beyond the trabeculations and try to get to this where you will end up with a very similar volume to the normal heart size. In reality, as much as you overtrace on echo for the biplane volumes, for very large hearts, it's still often less than what you get on MRI, and it's not that one of them is wrong and the other one is correct, but you have to kind of recognize that, and then the foreshortening is usually a bigger issue when it comes to echo, when it comes to these very large hearts. So this is what they found in this study when it comes to the trabeculations. If you actually trace all the way outside, excluding the trabeculations, you come very close to the MRI size. Whereas what we do often on echo is we're not able to resolve where the compacted myocardium begins, and we end up tracing more similar to this, and that leads to the underestimation. So this is the summary of this. Essentially, volumes are going to be higher on MRI, and then EF can be slightly higher or lower on MRI, but it's usually a few points. Now, beyond LV ejection fraction, there's a lot of work, but it's not, in high, utilization mode at this point on an MRI. You can actually do E and A velocities, and you can even get the annular velocities, and these have been tested to try to gauge diastolic function by MRI and gauge filling pressures by MRI. You can even estimate TR velocity, and you incorporate these along with the feature tracking to try to gauge the person's diastolic function and underlying myocardial stiffness. But in reality, this hasn't really been used in routine clinical care, and echo is still more than sufficient and still considered the reference for this. Like I mentioned, you can also measure the annular systolic exertion, or the systolic MAPSI, if you will, and that relates to outcomes when it comes to this study. And then strain is done with what we call feature tracking nowadays, where that also associates with outcomes in this example of patients with ischemic and non-ischemic cardiomyopathy beyond LGE. The advantage here is that you can adjust this tracing as you would, and you're not going to have issues with suboptimal tracking if the study quality is good, which, on echo, if you don't have the baseline study, for example, showing you the apical segments well, you're just not going to get a good strain assessment. So diastolic function and LV mechanics can be assessed with MRI, but not routinely used. And then my summary for this is, you guys already do all of this, but always think about getting an MRI in someone with a newly diagnosed heart failure, particularly in someone with an unknown etiology, unless you're very certain the patient has, cause X of cardiomyopathy. In reality, there's, even in more recent studies, about 10% of patients who have a dual cardiomyopathy or a coexisting cause of cardiomyopathy. So in the ESC guidelines now, this is a class 1A recommendation, class 1C. And then obviously if you're suspecting infiltrative, hypertrophic, exotic cardiomyopathy with toxicities and iron overload are also key indications for MRI. If you're uncertain about the EF, this is actually more common than you think. And then obviously for those with arrhythmias and no clear cause of arrhythmias or no clear structural cardiac disease on echo. And then the last thing is still sort of qualifying someone for device therapy or qualifying someone for intensifying medical therapy or starting in medical therapy for heart failure. You can still use the MRI, but the reality is nowadays I think that's a lesser used cause. And I will stop here. I think Dr. Chang should be starting soon. I don't know if he showed up. Questions, concerns, comments? All right. You're all ordering MRI, I can tell by being the Monday reader. So, all right. Well, let's see if he's here.
All right. Sorry about that. So I want to talk about how to evaluate LVEF function by nuclear and CT. You can see for the 2002 AHA CT guideline, it's considered that you use either CMR, CT, and nuclear imaging as recommended alternative for echo for assessment of LVEF. I think the order is right. You should always do CMR. And if CMR is not possible at this stage, if the renal function is reasonable, I think cardiac CT is a good choice. And nuclear, I think it's we use it occasionally. We never thought of it as a primary tool to assess EF, but it's also an alternative. It's kind of a lost art. We haven't done that for a long time, and but I want to show you what are the methods that you can calculate EF by nuclear methods as well. So it's two ways of calculating EF, fundamental different principle. First one, you label the red blood cells. Okay, so you label the red blood cells with radionuclide isotope. So you actually measure activities of LV cavity. You with me, right? So the isotope is labeled in the red blood cells, not be updated by myocardium. So you're not measuring the ventricular wall or the muscle mass. So you actually directly, what you see there is actual LV cavity, okay? So the method I've been using for several decades is MAGA, or the Caribbean radionuclide angiocardiography. So you label it, you inject it until the red blood cell distribute in the blood pool, and then you take pictures. Okay, so it's usually planar, so meaning you need to image the heart in two different projection, and then you try to open the septum, meaning that you can separate LV from RV, and you look at the number of counts that you get from that area, right? And then you measure the systole and diastole, you divide the number of counts, you get the ejection fraction. Pretty simple principle. It works very well. It's actually one of the first way of measuring EF. And not until recently, the oncology always want this because it's considered gold standard. Because they started measuring the EF change by cardiotoxicity medication with MAGA, and for a while it's hard for them to change their way of practice, so they keep ordering MAGA before and after chemotherapy. But nowadays, I think they're a little bit more open to echo result. Okay, so this is MAGA. I think last year we did several, no more than 10 in 2024. So it's kind of lost art, but anyway, it might show up in your board exam as well. So the advantage is no geometric assumption, because you're measuring the count activities, okay? It's very well validated, again, with invasive LV angiogram. Very, very reproducible. And because the frame rate is quite high, you can also measure diastolic function. And disadvantage is obviously a planar, and RV is usually not possible because of count, because it's hard to isolate RV completely from the rest of the cardiac structure. Remember, because everywhere in the red blood is going to be a count activity. Okay, and there's some source of error usually. You know, if you have to do it meticulously, open it, and if you have a background ratio, it has to be adjusted, and if it's ECG gated as well. So if you don't have good ECG, it's not going to work. Okay, second method is what we get. You know, it's like going to McDonald's, you order a Happy Meal, you get a toy. You know, so this is EF is what you order a perfusion study, and they give you EF, just a toy, and the toys has a lot of value to it, right? No one collect hamburgers, but people collect all those Happy Meals. Anyway, it's kind of stupid comparison, but you understand. So basically, we're getting this for perfusion, but you get the EF, okay? Every single study. So remember, you take advantage of that because it's free information. In the old days, you get paid even more, but not anymore. Everything's bundled. So anyway, so this is how it works. So basically, you wait until the isotope get into the heart muscle, basically, and so what you're measuring is what you consider endocardial border. And that obviously, it sounds obvious to you, but sometimes could be not so easy. So they have to come up with certain algorithm. It's called edge detection method, and you have a fixed threshold value level, and using complicated mathematical function and a statistical analysis of radial count profile. I don't even know what I'm reading, but basically you get the border, endocardial border, and epicardial border, and you have that, and you determine where the base of the heart is and where the apex is. Boom, you get it. Volume, you get volume, in diastole and systole, you get ejection fraction. So the protocol could be anything. It could be rest, stress, stress, rest, stress only. You can pretty much get EF, whether it's accurate is very important, because if you don't have counts, you're not going to have images. So low dose is hard, high dose is more accurate, and it's gated like most of the non-invasive study we do, meaning that patient go under the camera, and the camera is on. You start counting the photon coming from the heart. Remember, you actually measuring from the heart muscle, and you have to, after 10, 15 minutes of collecting thousands of beats, you determine which one is systole and which one is diastole. You divide the cardiac cycle into either 8 or 16 beans of counts, and you basically, then you got the contour in the end systole and diastole, you get ejection fraction. And as how crude this concept is, it works quite well. As you can see there, the volume compared to other method is quite reasonable. Obviously, there's some rules into it, meaning, again, this is an agreement between echo and SPEC, and you also have to compare MRI. And the agreement is, again, not perfect, but clinically works quite well. This is mostly for the bore. I mean, you can't take the data as the software spill. You need to look at the image quality and the data quality. And how do you look at it? You look at the sinogram, okay? So the problem is, this is the caveats. If you have inaccurate contour finding, meaning that you can see the images, don't turn off the contour, because you want to make sure the contour is including the heart, LV only, because if you have a hot bladder or hot liver, you can spill over there. You might think the liver is a heart, and obviously you're going to get a completely ridiculous answer, right? And the problem is, if you have low dose, and because the spatial resolution of the SPEC is over 1 centimeter, think about it. If you have a myocardium of 0.5, 0.6 centimeter with infarction, if you have spatial resolution 1 centimeter, this is not going to be accurate. So there really some caveat you need to see. So especially patient with a small heart is an issue, and it's subjected to arrhythmia. We're going to that's obvious, because if you have a lot of arrhythmia, you can't differentiate. You can't really detect the true end systole and diastole. And RV assessment, because RV mass is so low, the activity is very, 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 very dim. You can't really realistically measure RV-EF. And the low frame rate. So EF is underestimated, because usually we do only 8 frames, and unless if you do 16 frame or 32 frame, otherwise it's going to be not accurate. And you would say, why don't we do just higher frame rate? But if you have a lot of frame, meaning that you have less count per frame, and again, it's a trade-off. Okay, and this is one thing that you need to look at, the sinogram, okay? Usually rotate, the camera rotates through the heart around the patient, so you're going to detect heart is going to be seen like a sinus wave, okay? And then you look at the count histogram. If you see huge spikes, usually that's not a good thing. Example here, okay? Like you see stripes again through the sinogram, and in the histogram you see a huge spike. That's a sign of trouble. Remember, okay? In that case, you want to throw out the EF, and especially you can see that the algorithm usually determines that if you have beats more than 10 minutes variation, it will be discarded. So if you have a lot of PVC, very variable EF, it's the same thing with the CT. It's not gonna be reliable. All right. And as we talk about this, so if you have patient with huge infar, and the contour not gonna work very well. As one on the left-hand side, it went into the abdomen. But sometimes, if you have severe apical defect and huge anterior infar, LAD, proximal LAD infar, all you have is some lateral wall and inferior wall. You're not gonna have good contour. But you will be surprised. Sometimes you say, where is the count activity, and actually give you pretty good tracing. So it's all about not just taking out the EF, but also always look at the image that you get and determine if it's reliable or not. And the small heart underestimation, they gave EF more than given EF a 90% end systolic volume of 3 cc. That's you all read the echo. That's not possible. But so you need to know the small heart EF is overestimated. And why is that? This is a partial volume effect. We talk about it a lot, but this hopefully I want to spend two minutes to explain. It's mainly due to two reasons. It's due to the problem with the imaging equipment. The spatial resolution is finite with the imaging system. PET is about 5-7 millimeter, and SPEC 10, and you can improve that a little bit. But so that's due to the innate limitation of the imaging system we have. And this is kind of what it is. In the left-hand side would be what is actual objects, and under the camera it looks like one in the right-hand side. Okay, so that's and then this is kind of like a very simple explanation. If you understand this, you understand what partial volume effect is. So example is in the left-hand side, the actual activity count is 10 and the background is 5, right? Because the spatial resolution is not perfect, right? The smaller resolution, if the spatial resolution is what is illustrated in each pixel, you can see that anything that is more, if it is right in the middle, within the pixels, so only one in the middle has actual detection with activity counted would be 10, right? So if the image quality, if image, for instance, and one would say 8 because it doesn't occupy the entire pixel. So if you look at the difference of 10 and 5, so you actually see you have spill in and spill out, meaning that if it's the actual object occupied less, and what's half of the actual pixel, you're going to have spills out, and the other way around it spills in. So if you look at the measured images, and that's what it is. So and that's what determines partial volume effect. You have spills in and spills out, and they give you inaccurate border detection. And the reference value, you can see that this is why the EF that you get from SPEC is always lower than echo and sometimes MRI, and there's a reason for that. So these people have looked at this, and the patient with a lower EF, like even with PET, depending on the system, the ejection fraction could be considered normal in even 50s, in the mid 50s, and this is SPEC. So if you compare to MRI, usually 3 to 10% lower. So higher dose protocol, as we mentioned, obviously is going to be more reproducible, and different reference with different vendor. That's also an issue. And this has also been done with PET, as you can see here. This is a normal reference in patient without any risk factor in the left-hand side, and compare the patient with normal CTA, which we can argue if it's a good standard or not, but pretty much excluding patient with chronic disease. This is basically patient with normal volunteer, so you can see the EF, depending on the software you use, could be lower. And why is PET is important in EF that we get? Same thing with SPEC, right? I mean, you get additional information in terms of prognosis and help you differentiate, difficult perfusion cases. Like this study published by Dr. Malahfji showing that if you add EF, resting EF and differential EF, meaning that EF post-stress should be higher compared to resting. So if you don't increase your EF with stress, it's usually a bad prognostic sign. All right. So remember, this is nuclear. How about CT? So occasionally we get study like this. Okay, I don't know. It doesn't play. All right. This is the patient who needs TAVR, and you can see even with contrast, I mean, still, you can get a guess at EF. You know, it's normal, abnormal, mildly depressed, but you want to give a number, it's a challenge, right? And okay, and as you can see here, you can really see the EF here. This is the same patient, and I think you can very confidently use this EF here. And why is CT even consider a reasonable alternative? You know, you can do single breathal, and with a big detector, like white detector CT, those GE or Toshiba scanner, if you can get a 1B acquisition, you can even, with single B, you can get a EF. And it's isotropic, as we discussed it during the CT lecture. It's the same throughout 3 axes, there's a spatial resolution, there's no distortion, so there's no partial volume effect, meaning that this is truly one of the few techniques that you can say, you know, if you use a high resolution mode, there's very little, no technology is without partial volume effect, right? Unless you have in a perfect spatial resolution, but it's as low as you can get. And temporal resolution is a challenge. I put good here, but it's actually probably the worst compared to all the MRI or echo, but it's reasonable. Its heart rate is good. It's a good contrast. It's a very good contrast between LV and RV, LV mass and LV cavity. And you can do it when you have device. And there's a couple of ways of doing it, and this is the concept is isotropic resolution, as you can see there. So in all 3 axes, you have the same, so the partial volume effect is similar and reduced to as low as possible. So if you have good spatial resolution, you can have the most accurate volume data set. That makes CT almost, I would argue, probably the best non-invasive technology to measure a volume accurately, yeah. And there's a couple of ways of doing this. You can do the 2D methods, same thing with similar thing that you do in the MRI lab. You can trace it using Simpson methods. That's very standard. And because of the contrast between the LV mass, LV muscle, and LV cavity is very good, you can just look at the threshold, the difference. If you have a voxel with very good contrast, attenuation, and very low, that's a border. So you can do threshold-based 3D segmentation. So there's no geometric assumption because we have the isotropic voxel property. And obviously you can use AI using both, combination of both methods. So most of the software you use have a little bit of both, so AI-based. And you can do LV and RV, there's no limitation. As long as you can always differentiate where the RV cavity and RV muscle if you have reasonable weight contrast. And the caveat, obviously, if you have arrhythmia, you're gonna be off, right? And 3D, because the contrast threshold base, you need to have homogeneous contrast. If you have area with a low flow, like aneurysm, that would not be kept. But you can always correct that manually with your software. And with CTA, you can see that correlations is as good as it gets because both methods are quite similar. And the caveat, as we mentioned earlier, is the temporal resolution because the temporal resolution is not as good. If you have a high heart rate, it's impossible to get the true end systole or end diastole, right? If you think about it, if you underestimate 5 cc for each, that's 10 cc over stroke volume. There's a significant impact into EF. So EF is usually lower when you get with CT, unless the heart rate is slow. And that's why we insist if you want to do EF calculation, you need to get 20 phase rather than 10 phase, because that increases the chance of having getting the EF here. So like this example here with 10 phase, you get slightly lower EF, and with a 20 phase, about 3 to 5% higher. Okay, you can easily see the images. The 20 phase is a lot smoother. The other one is a little more, I would say, that choppier. And obviously also depend on your algorithm. Do you include the palm muscle? Do you exclude that? If you use the threshold method, you would exclude that, because if you increase the threshold, then it's easy to exclude palm muscle. But if you lower your threshold, it might spill over and count part of the palm muscle. All right, so depending on, and the other thing is obviously we use beta blocker. Sometimes you could lower the EF. And the normal value the problem is there's no database or normal populational study using CT. The MRI there is, so it's a challenge. When you get in volume, we don't really know exactly what's a normal reference. And how do we scan the patient? We use the thing only retrospective, the way you can do it. Now we know that with the advanced assistant, EF is feasible with prospective. Okay, you can image a patient in end-system and diastole prospectively. You can see the left-hand side, that's how we did it. Or you can do high-pitch mode. Okay, you can just take a snapshot and end systole, take a snapshot and end diastole, and I use that all the time. And this is example of patient and that only allows you to get a sense of LV function. You can, in some cases, I think it's very useful. I think the fellow who read with me heard about this ad nauseum. If you have a questionable lesion and you have this wall motion, the anterior wall is not moving as well, and you can comfortably say, hey, you have a patient with chest pain, you have a indeterminate lesion, but your wall motion is abnormal. Well, I think to increase your confidence, calling the lesion normal. The opposite is not the same, right? Because you could have a tight lesion with normal resting motion, but if you have abnormal wall motion with a looks like a tight lesion, I think it's very specific. Okay, so that's important. And the other thing that we've been working on, this is obviously not mainstream, but I've been doing this research. We try to use calcium score imaging to using AI with EF. You can see the correlation is quite reasonable. In left atrium, right ventricle is very accurate. Correlation is good, and we took it a stage even further. This just got accepted in one of the baby journal of European Heart. And you can see we got a non-contrast imaging in end systole and end diastole, and we're using CTA as a gold standard. You can see left-hand side would be a patient with. So for instance, in the left-hand side is a patient in end diastole, a normal EF patient, and the second column with the patient end systole. You can see. So end systole and diastole, and the right half of the image is a patient with low EF. You can see the cavity is larger and the stroke volume is smaller. So this is how we did in 200 patients, and you got pretty reasonable correlation. And what is this good for? I mean, you can imagine if you do a calcium score images, if you get additional low dose scan, and you can screen the patient with reasonable specificity or low ejection fraction in asymptomatic patient, that could be very useful. Instead of only detecting asymptomatic coronary arteriosclerosis, you can hopefully detect all patients with LV dysfunction. And I think it has its clinical utility. Anyway, and just to mention, CT, you can do strain imaging as well, okay? We don't do it because, you really need a good contrast, and at this stage, echo is well validated. So this is just one of those things that I can do this trick as well, but really, I don't think too much of clinical application. Okay, that's all I have. In conclusion, volume and EF is definitely feasible. So consider alternative if you cannot get a EF by echo, typical situation, patient with LVAD. Okay, so you cannot do echo. Echo is not good quality. MRI is out of question. You can provide additional prognostic information. It's essential for patient with difficult image by echo. And but always use that information. Remember, when want to image the coronary or image the ischemia or infarct, you get the EF. So don't just pay attention to it because it help you interpret and help you manage the patient. Okay, that's all I have. Any question? Go ahead.
Dr. Malahfji talked about how the MRI volumes, the cardiac volumes on MRI are much bigger than what we get on echo.
Yeah.
What about CT? Are they similar to MRI?
Similar MRI, very similar. Yes, yes. Because MRI, if you remember MRI, you guys, what we do usually, they sample how many slices, 10 or 20, right? Remember, they always talk about the true volume depending on where they put their limit is, right? Depending mostly at the base, right? If you get the true base or you didn't get the true base. And I don't think they're doing true 3D MRI yet. They are. It's available. Too bad Dr. Malahfji is not here. She's still here now. So you guys have done MRI. Correct me if I'm just talking nonsense, but my understanding is routine MRI you guys do is not 3D MRI, right? You're still using Simpson methods in a sense, very similar, right? So depending where, if you determine where the limit of the base of the heart, it could impact. Clinically, is obviously that is irrelevant, right? If you get those 2, 3, 4, 5 cc, it doesn't really change anything. But if you want to do a clinical research and you want to detect the changes, that's important. So my field of MRI is, that's a technical challenge, obviously, and also the is not a isotropic resolution, okay? So that's also a limitation, and unless you do 3D, and and in order to be accurate, I believe you need to do the best resolution is you need to do 0.5 millimeter. It's really close to. That's been done with the cast. So basically, they do animal study, and they feel the cap. You can feel the heart with some type of materials, and that's true. That's a gold standard. So given that limitation, I think LV and RV correlation that I show you, they're excellent. I mean, the difference is 5, 10 cc, in a 150 cc heart. That's really minimal difference, right? Especially with EF, if you have difference, that could be almost minimal. What I think the main difference you see, no one has studied, is the atrium, right? And I think that's the reason why you guys don't report, when you do MRI, you don't report atrial ejection fraction, right? Because you only report atrium and end systole, I believe. And that's, I don't know exactly how you derive that, but I find that sometimes the atrial volume is also much bigger than MRIs and CT as well. If you pay attention, we report almost, you never see a patient with a 50 cc left atrium in a normal. So I think if you have a good heart rate, I would say that clinically there's no difference between LVEF and volume derived with CMR and CT. But I would argue if you use the best resolution, we have a 0.2 ultra high resolution CT, patient with a good EF, and you give good contrast, I think that would be closer to the gold standard of true volume. But clinically, it's really irrelevant, personally. But in short, your answer to your question is LVEF volume obtained by CMR and the CT is much closer than the difference, much smaller, I should say, than the difference you're going to get between MRI and echo, because fundamentally the concept is similar. Okay. Thanks for staying late. Did I finish early?